right side, a lot of time you find first the vein, the genital vein, and then in a deeper position you will encounter the ureter. In some patients with a very huge pelvis and with not too much fat, it's possible to go directly to the pelvis and to reach the junction directly. But you will see on a little video, in most of the case, you reach first the genital vessel and then the ureter, and then you follow the ureter towards the direction of the pelvis. In half of the patients that we are operating for pieloplasti, the CT scan told us that they have crossing vessels. So you know that you will encounter those vessels, and you have to liberate those vessels from the ureter and to preserve those vessels to avoid any ischemia of your kidney. So in this slide, you see you have a huge vein and probably an artery also in this pedicle, which is crossing the junction, and the junction has been liberated from behind, and you see the pelvis is over there, and that's what you try to do, because you will decross the ureter from the crossing vessel. You will place the new pieloplasti in front of the vessel. And for people who are rating by a retroperitoneal approach, and it's in the literature, the percentage of patients with crossing vessel are less important, and probably in some cases they don't see the crossing the vessel which are in front of the ureter. And then you have to section the ureter just under the junction, 1 centimeter under, and to do a spatulation. Either you cut it completely and you do the spatulation, either you cut only half of the ureter and then you introduce the tip of the scissors to perform the spatulation. Here is the spatulation with a ureter completely sectioned. The length of the spatulation should be 2 centimeters to 2.5 centimeters, and it's better to do it with straight scissors, but in some cases you only have the curved one. Then you have to remove the excess of pelvis. One advice is to avoid any too important resection of the pelvis, because you must be careful with the calyx and the infundibulum, and it's never necessary to have a too extensive resection of the pelvis, because after you relieve the obstruction, most of the time you have a retraction of the tissue, and then your pelvis is reducing of size. If the removing pelvis is important, you can place it in a bag, or in most of the time you can remove it through one of the trocar directly. Then it's a time for anastomosis. You can use running suture or interrupted suture. It depends on what you are used to. You will see in this slide, this is running suture. So you start on the pelvis at the lower part of the pelvis, and then the stitch will pass outside, inside in the pelvis, inside, outside in the spatulated ureter, and then you have your first knot which will be done, and you will then suture the posterior aspect of the pelvis to the posterior aspect of the spatulated ureter. Then you do the anterior, then you will place at this time, because then the ureter will be nicely fixed to the pelvis, and you can introduce the double G stent. There are different manners to do it. We use, for ourselves, we use stents, you see, which have a closed tip. So that means that the guide wire is inserted in the double G, but with the rigid tip inside, and you just push the guide wire with the stent in the ureter, but you can introduce the guide wire first and push the double G over the guide wire. It's also possible. But we were doing this in open surgery, and we keep the same habits by doing laparoscopy. And when the double G is in the bladder, you can remove the guide wire. Or when you are not sure that you are in the bladder, you can empty the bladder with glue and to see if glue is refluxing through the ureter. There are different tricks that are possible, but most of the time you feel it going nicely. It could happen that the double G doesn't progress in the ureter, so my advice then that you place maybe only a guide wire, that you can, at the end of the operation, take by doing a cystoscopy and remove the guide wire completely, and then you can find there are different tricks that you can use and do, placing your double G by a retrograde way. Then you have to complete your anastomosis by doing the anterior suture. The first part will connect the anterior aspect of the pelvis to the anterior aspect of the spatulated ureter. And then most of the time, the opening of the pelvis is much more large than the one of the spatulated ureter. So you have to close the tip. Here you have to close the end of the pelvis. See, when you completely fix the ureter on its anterior aspect, you have to close this part of the pelvis where you have a larger opening. On this drawing, you have the representation that has been shown on the slides. So, first of all, you suture the posterior aspect of the spatulated ureter to the posterior aspect of the pelvis, only on a limited length. And then the anterior suture will connect the anterior aspect of the ureter to the anterior aspect of the pelvis, and then you close the excess of opening of the pelvis. At the end of the procedure, you can place or not an aspirative drain. It depends of each habit, and then you remove the trocars always under direct vision. The drain are removed when they are not producing any more liquid. Then you remove the Foley catheter between day 2 or day 3, and hospital discharge generally between day 3 or day 4. And then the double G is removed in an outpatient procedure 3 weeks later. Laparoscopic pieloplasti is a technical demanding procedure because you must be confident with suturing, but there are advantages for the patient. You have less pain, less scar. It seems to be the gold standard procedure for UPG obstruction treatment, but for a well-trained laparoscopic surgeon. So we will see now a little video which will illustrate all these different points. It's a patient with a right UPG obstruction. You can see the liver, so you introduce the trocar under the vision, and the kidney is over there, and you see, you don't see the colon, or only a little bit here, because it's falling down, and what you have to incise is the peritoneum at the level of the lower pole of the kidney. So if you have huge pelvis, sometimes you can incise directly to the pelvis, but there we will incise the peritoneum at the level of the lower pole of the kidney to look for the ureter, and you have to remember that before seeing the ureter, generally you will see a vein. It could be the vena cava, it could be the genital vein, but most of the time you see first a vein. So you can notice that the surgeon is using on his left hand bipolar grasper, and on his right hand the monopolar scissor. Here you have the lower pole of the kidney, and you progress slowly, and with the gravity the column is falling down, and you can see, we can notice by transparency that some elements are coming. So is it the ureter? As you see, the ureter is there, and there this was the vena cava at this level. So the ureter is more wide, and you have a movement of the ureter, which are characteristic. So it was quite an ancient video, this one, and you see what's not recommended is what I was doing there. It's grasping. The grasper are automatic, but if you can, it's better to catch the tissue which are surrounding the ureter than the ureter itself. Okay, and then you are progressing towards the pelvis, and you can notice in this patient we were, after the CT scan, we were aware that he has a crossing vessel, and those vessels are over there. You can see, and so you will smoothly dissect the ureter from those crossing vessels. You have to liberate all the tissue which are attaching the ureter to those vessels, and the larger those vessels are, the more cautious you must be, because otherwise you create a large ischemia of the kidney if you have any injury of those vessels. So the liberation from under seems to be enough, so you try now to reach the pelvis over the crossing vessel, to remove all this fat, and to trying to find the pelvis over the crossing vessel. See, on this patient there were some adhesive adherency, so adhesive attachment all around the ureter. When going over the crossing vessel, you must be careful, because you will find the renal pedicle in a higher position. Normally it's much higher, but you have to be cautious also. You can nicely see here the crossing vessel, but with adhesive tissue all around. By pushing, by doing smooth dissection like this, you can progress. It appears to be already the pelvis, because it's much more large than the ureter. So that means here you have the pelvis which has been reached over the crossing vessel. And before cutting, you can try to complete the liberation of the pelvis, to have a good mobilization of the tissue. It will be important for the anastomosis to avoid any tension when you will perform it. Then you have to cut the ureter just under the junction. So here it's a complete section. And you do the spatulation on the posterior intern aspect of the ureter to know where to incise. You just have to leave the ureter, and it will take normally the good position. Then you decide, you see, to incise on the posterior aspect. Then you will completely detach the pelvis from the remaining attachment. To decross, because your anastomosis will be in front of the vessel, and the vessel will be behind. And to have a good mobilization of the pelvis, you see, you complete the attachment liberation. Then it's the time to remove the junction. Normally, it's it's particular on this video, you see, because I only removed a little portion of the pelvis to create a larger opening. But as I have not too much tissue here, I wouldn't cut over there because otherwise the anastomosis will be under tension, you see. But most of the case you completely remove the opening, and then you start the anastomosis. So outside, inside at the lower part of the pelvis, and you go on the spatulated ureter at the lower part also, but inside, outside. And then you perform your first knot, which will connect the spatulated ureter to your pelvis. And you continue with the running suture. Here, again, outside, inside on the pelvis, and inside, outside on the posterior aspect of the spatulated ureter. You see, I leave this little part of pelvis. Normally, it was for my assistant that by lifting it, it can help you. It's a trick which is not necessary. In some cases, it can be useful, but it was done on this video, so you can see it. So you continue, you have 4 or 5 passage of the thread, connecting the posterior aspect of the pelvis to the posterior aspect of the spatulated ureter. So that means that you will have a good fixation of your ureter to the pelvis. That's important before introducing the double G stand to avoid any tearing or any disruption of the suture when you will push the stand. And then at this time you can remove completely your excess of pelvis. Complete the fixation of the ureter. I think it's important to have the complete fixation of the whole length of the spatulated ureter through your pelvis. So that means that probably you will have a large opening of the ureter, and to avoid any obstruction by doing the pieloplasti. So this is your second knot. Then the double G is introduced through the trocar, which is under the costal rib. And you see you can hold the double G by 2 graspers, and you progress directly with the double G, which is straight because you have introduced a straight part of the guide wire. And when you are at this level, normally you are in the bladder, then you remove the guide wire. And you have only to introduce then the upper tip of the double G stand in the pelvis. Okay, then you proceed to the anterior suture with a second running suture, starting at this angle, outsiding in the pelvis and inside out in the ureter. That will fix the anterior aspect of the spatulated ureter to the anterior aspect of the pelvis. Laparoscopy, you can nicely see the place where the needle will enter and will get out of the tissue, and to try to have a regular suture. beginning, when you are not used to the suture, this is technical demanding, and many problem can occur. You can have tearing of the tissue, you can have some difficulties. If you are more confident with interrupted suture, my advice is to do interrupted suture first, maybe. Yeah? Depends of what is your experience in suturing. And then when the ureter is completely fixed here to the pelvis, then you have to close this part of the pelvis, which is the upper part, and you can close it with the same thread. You continue the running suture until you reach the top of this opening. So that means that you use only two threads. And this is the fourth knot that you have to do. So you don't place any drainage. We are used to place this kind of Renault drain. It's not necessary to close the peritoneum because when the patient will be on the back, I think the colon will fall down and it will be covered immediately. And that's the end of the procedure. So if you have